The disruptive and impulse control disorders are characterized by primary features of emotional and behavioral dysregulation, impulsivity, and sometimes aggression and rule breaking. In this snapshot, we will be providing a basic overview of oppositional defiant disorder, conduct disorder, intermittent explosive disorder, kleptomania, and pyromania. Some people associate this group of disorders with children and adolescents, but many of the impulse control disorders are also diagnosed in adults. Before attributing disorders due to an underlying psychiatric etiology, you need to first consider several other possibilities. First, you need to consider if the symptoms represent an expected and developmentally appropriate response to a situation. Asking about the symptoms in relation to baseline can be helpful. The disruptive behavior disorders are characterized by recurrent patterns and specific symptom clusters associated with disruptive behaviors. Most quote-unquote bad behaviors are not psychiatric in nature, especially if there's a clear motive to the behavior. This is a question often explored by forensic psychiatrists. In the case of impulse control disorders, there's a degree of inability to suppress or overcome underlying impulses that is central to the larger pattern. Before making a psychiatric diagnosis, it's important to first exclude medical diagnoses that better explain symptoms. Obtain a thorough medical history, vital signs, and physical exam. Getting a thorough medication history and timeline of symptoms in relation to starting and stopping medications or substances is helpful and should be part of a comprehensive medical and psychiatric assessment. Substance use disorders can be comorbid with some disruptive behavior disorders, and some medications and substances can also worsen impulsivity. You also need to assess whether the individual has another psychiatric disorder which might better account for the presenting symptoms. Depressive and anxiety disorders, trauma, and psychosis are characterized by irritability and behavior changes in children, and if present, may require entirely different management. ADHD is a common co-occurrence with disruptive and impulse control disorders. A thorough psychiatric review of systems is a good way to help narrow down your psychiatric differential diagnosis. We'll start with oppositional defiant disorder, which is a common concern in pediatrics practice. Oppositional defiant disorder, or ODD, is a pervasive pattern of angry or irritable mood, argumentative behaviors, and or vindictiveness. It is pervasive in that the behaviors must be present for at least 6 months and in multiple settings. Therefore, you can't make this diagnosis if, say, the behaviors only happen at home with a sibling. A pattern of at least 4 symptoms must be met, including frequently losing temper, being touchy or easily annoyed, being angry or resentful, frequently arguing with authority figures or, for children and adolescents, with adults, defying rules, deliberately annoying others, blaming others for mistakes or behaviors, or being spiteful or vindictive at least twice within the last 6 months. Normal development is important to consider here, as there are periods of time such as toddler age and adolescence during which behaviors that can be perceived as oppositional are actually normal and expected. Toddlerhood and adolescence are 2 periods of development during which a child is working on establishing identity and questioning the world around them. In ODD, however, the testing of rules and limits goes too far for too long with too many people and becomes problematic. ODD is generally a childhood diagnosis. Conduct disorder is a sharp contrast to oppositional defiant disorder. It crosses a line from ODD in that basic safety rights of others and societal rules are violated. Because the symptoms and behaviors are more severe, you only need 3 to make the diagnosis, and you have a longer time frame to capture them, a year. An individual may not meet all 3 criteria at the exact same time. They just need to meet 3 in that same 1-year period. One of the symptoms must be relatively recent in the last 6 months. Deliberate is a key term here and is a hallmark feature of conduct disorder. Symptoms of conduct disorder include bullying, threatening or intimidating others, initiating physical fights, using a weapon to cause serious harm, being physically cruel to people, being physically cruel to animals, forcing someone into sexual activity. Deliberate fire setting with intent to cause harm, not just playing with fire that goes awry or being really interested in fire. Deliberate property destruction, breaking into someone else's property, lying to manipulate situations such as trying to obtain or avoid something, stealing items regardless of their value, breaking curfew before age 13, school truancy prior to age 13, or running away overnight at least twice. Often, there is a lack of remorse for behaviors. Kids with conduct disorder may feel justified for their actions, lack empathy for the victim, or exhibit other callous, unemotional traits. And like ODD, conduct disorder is a childhood diagnosis. If you like picture representations, this is for you. You can think of ODD as the bark and conduct disorder as the bite. Both disorders feature disregard for authority figures. Kids with ODD and conduct disorders may struggle with parents, teachers, or anyone else who tries to tell them what to do. ODD is less severe and requires more symptoms for diagnosis over a shorter time frame. Conduct disorders cross the line into violating laws and safety. Because of the severity, fewer are required. However, a one-time episode of harming another person or breaking a law isn't conduct disorder. It is a pattern of these behaviors over a period of time, the last year. ODD can progress to conduct disorder, and conduct disorder can further progress to antisocial personality disorder in adulthood. Next up, intermittent explosive disorder. This is a disorder characterized by failure to control aggressive impulses, resulting in recurrent behavior outbursts in one of two ways. The first is verbal or physical aggression that occurs on average twice a week for at least a 3-month period. The aggressive outbursts are less severe and don't result in property damage or injury, but are more frequent and still really disruptive. The second is 3 behavioral outbursts in the span of a year that are so severe that they cause property damage or injury. These are higher level offenses and therefore you need fewer of them to meet criteria because of their severity. In either case, the resultant outbursts are out of proportion to the event that triggered them. This diagnosis cannot be given in children younger than 6, as temper tantrums and behavior outbursts are part of normal development at those ages. The outbursts are also not premeditated or manipulative in nature. They are based in anger and inability to control that anger, and this is how this can be differentiated from conduct disorder or antisocial personality disorder. And between episodes, mood returns to baseline in intermittent explosive disorder. There's often genuine remorse after the outbursts. One question I commonly get is how to differentiate between intermittent explosive disorder and disruptive mood dysregulation disorder. Both disorders are characterized by recurrent behavioral outbursts that are out of proportion to the inciting trigger. Both can begin in childhood with a minimum age of 6 for IED. Symptoms must be present by age 10 for DMDD. In intermittent explosive disorder, the outbursts are less frequent. They occur twice per week for at least 3 months if no property damage or physical injury results from them. If they're so severe that physical injury or property destruction occurs, then only 3 events over the course of a year meets criteria. And importantly, that baseline mood between outbursts is euthymic. This disorder can also have onset in adulthood. IED is depicted on top in red on this graph. Disruptive mood dysregulation disorder is a depressive disorder. It is a disorder of childhood, and symptoms must be present before age 10. Outbursts occur more frequently, at least 3 times a week, and over a longer time frame, at least a year. Importantly, the baseline mood between outbursts is irritable or dysphoric. DMDD is depicted on the bottom in blue on this graph, again because that baseline is shifted down and more irritable. Kleptomania is an impulse control disorder in which an individual is unable to resist recurrent urges to steal items that they don't need. The behavior needs to be recurrent, not just a one-time event. The items usually aren't of any significant value. Typically, there's a build-up sensation of tension that stealing helps to relieve. And importantly, the stealing behavior isn't motivated by anger or revenge, which might better characterize it in context of conduct disorder or antisocial personality disorder. The stealing behavior also cannot be in response to hallucinations or delusions commanding a person to steal, which would then probably better characterize it as a psychotic disorder. Pyromania is an impulse control disorder in which an individual is unable to resist recurrent urges to set fires. People with pyromania also have a fascination with anything related to fires, including paraphernalia or consequences of fires. Like in kleptomania, there's a build-up sensation of tension that setting or seeing fires helps to relieve. And importantly, the behavior isn't motivated by anger or revenge, which might again better characterize it as a conduct disorder or antisocial personality disorder. And the behavior cannot be in response to hallucinations or delusions, which would probably be better characterized by a psychotic disorder or in the context of any substance use, which would impair the person's judgment. Here are the disruptive and impulse control disorders folded back up into our bigger framework. Let's summarize. Oppositional defiant disorder is characterized by anger, irritability, defiance, and vindictiveness, but does not violate others' rights of safety. Conduct disorder takes ODD a step further into the realm of rule and safety violations. The behaviors often have legal consequences. Intermittent explosive disorder is characterized by verbal and/or physical aggression and outbursts that represent uncontrolled anger that are not spiteful in intent, but rather happen with little to no provocation. DMDD is a depressive disorder, not a disruptive or impulse control disorder, but is so close to IED that I'm including it in this summary chart for your review. Kleptomania is an impulsive, recurrent stealing and is not motivated by revenge, need, or command hallucinations or delusions. And pyromania is impulsive, recurrent fire setting, again, not motivated by revenge, monetary gain, delusions, or command hallucinations or delusions.